Okay. Hi, everyone. We are so excited today because we have Dr. Dylan Sharma that is going to be talking about a case study today. We are so excited to have him, and I'm going to pass this along to Dylan.
Thank you guys for having me. I'm so excited to talk about this case study. I'm Dr. Dylan Sharma, as Nadia said. My Instagram handle is actually at Dr. Dylan Sharma if you want to take a look. And let's get started. So just a little bit about me. I'm Canadian. I'm from London, Ontario, Canada. I went to Western University for my undergrad. I studied kinesiology, actually, which is a different undergrad to do than a lot of what other people do in dental school. Most people do medical sciences or general science or something along that line. I did a bachelor's of science in kinesiology, graduated in 2019. Had some of the best years of my life at Western. I'm so glad I did kinesiology. There's just so much you can do with it. And then for dental school, I actually went to school in Ireland. So the school I went to, UCC, or University College Cork, it's accredited in Canada. So there's only a few countries that are accredited. There's Australia, New Zealand, and Ireland. So it's just one of the programs that you don't have to really do any additional, you don't have to do any additional schooling when you're finished, just your board exam. So I just graduated recently, class of 2023. Had a great time in dental school, great time in Ireland. And some stuff about me, like my other hobbies, I love to golf, love to stay active, exercise, play tennis. I'm also like a content creator. I like to create stuff on Instagram. I've had an Instagram for the last few years, so I started it when I started my second year of dental school during the pandemic, and it's just a great way of networking, especially with the whole Desidentists thing. It's cool that we were able to connect with people from around the world and do all that stuff. I actually also have a podcast that I started. It's called the Tooth Doctor Podcast. If you're interested in, I talk to people in dentistry, dental students, dentists, dental hygienists, all that kind of stuff. But I also talk to people in other healthcare professions, such as medicine, nursing, chiropractor school, physio. So if you get a chance, it's a good listen. Kind of plugging my own show here, but yeah, no, it's a good listen. It's fun. It's only like 25 minutes. You can find it on Spotify and Apple Podcasts. So let's get into it. Why we're here is to talk about a case. So a case is like when you have a patient in your chair and they come in, there's just so much to take in. They may have an issue, like a problem that they're coming in with, like say maybe pain or something along that line. Maybe they don't like the appearance of their teeth. We don't know. But just you have to take your history, you have to take your proper clinical exam, kind of get to the root of it. But before you kind of do that, you have to like think about it, things like strategically and kind of systematically. So I kind of have like like 5 steps that to approach a case. So I like the acronym "A person sings delightful melodies." So the acronym is for acute, prevent, stabilize, definitive, and then maintenance. So basically, you want to first treat the acute problem when you see a patient. This could be an example of, say, they come in with pain or something along that line, or they fracture their tooth. So you want to treat that acute problem while it's bothering them. You want to get them out of pain or whatever it is, infection. Then the next thing is prevent future disease. So something that's important with dentistry that sometimes is overlooked is preventing stuff before it actually happens. And this is really important. Stuff like oral hygiene, like just dietary advice, that's really important. So once you kind of get them out of their acute problem, you want to make sure you prevent any other disease from coming on. And then if you see other active disease, which we'll talk about a little bit more later, you want to stabilize that before you start any definitive treatment, such as like fillings or crowns, dentures, whatever. But you want to make sure you stabilize that active disease. And then once you're done all that, you do your definitive treatment. Then you want to maintain whatever the oral health, and you want to maintain whatever you accomplish in keeping that mouth very healthy. So let's look at the example here. I just kind of took something that I did in dental school and I kind of created like this case similar to some of the ones I did, but like I just kind of made this dialogue up, but similar to what I had kind of dealt with. So I fractured my upper front tooth as I fell down the stairs. I don't have any pain in that tooth, but I do not like the appearance of it. Some of my teeth feel very sensitive when when I eat cold drinks and foods. I do not brush I do not brush my teeth very often, but I need to get better at that. I never floss or use mouthwash. This is my first time I've been into my dentist in over 10 years. Also, when I brush my teeth, my gums start to bleed. Is that normal? Lastly, I'm missing some teeth on my upper right and left side. What can be done to replace those? So that's a lot. And usually, like when a patient comes in, they will give you a lot of stuff, and you're writing down the reason for attendance, and you're just trying to get the important things. So we can kind of just take a look at this like in like the paragraph. So we see right off the bat that he fractured the tooth. So you're thinking, okay, well, is the tooth okay? Is he in pain? Is the tooth vital? That we have to check that out first. So that's on probably priority number one when you're looking inside his mouth. That's probably the acute problem. So he did say that he didn't have any pain in that tooth, but that doesn't necessarily mean that there is an infection. He may need root canal. The tooth may be non-vital. So we have to do our vitality tests and like our radiographs. He also doesn't like the appearance of it. So obviously a fractured tooth is not great for a lot of patients since it's at the front of their mouth. So they want something done about that. Crowns sometimes take a little while. So it's not like, oh, we can just do a crown right today. And then usually we have to maybe do something temporary before we start the rest of the treatment. So he's also said that some of his teeth feel very sensitive when he eats cold foods and drinks. That could be a lot of things. It could be like just plain sensitivity. It could also maybe be reversible pulpitis or something along that line. We can't exclude that. We have to look at all the differential diagnoses. So he doesn't brush his teeth very often. So we have to figure out when he does actually brush his teeth. What are we talking here? Are we talking once a day, once a week, once a month? We have to find that out. And it might sound kind of crazy, but sometimes patients don't brush their teeth for a long period of time, once a week. It's not something that everybody just knows that you have to do. We know that because we're in dental school, we're in dentistry or whatever it is. But some people don't know, and that's not to their own fault. Some people just don't know these things, and that's our job as dentists or dental hygienists to educate these patients. He also says that he never flosses or uses mouthwash. So flossing obviously is very important for periodontal disease. So that'll come up later. This is my first time that he's been to the dentist. Sorry, this is the first time he's been to the dentist in over 10 years. So that's a very long period of time. And we have to think, why hasn't he come to the dentist in 10 years? Is it because he can't afford treatment? Is he afraid? What are the underlying factors why he hasn't been in so long? So we have to take a look into that. He says when he brushes his teeth as well, his gums start to bleed. Is that normal? Well, we know that's not normal. What is it? Is it just gingivitis? Is it periodontitis? We'll have to take a look at that as well. And then lastly, he's missing some teeth on his upper right and left side. What can be done to replace those? So there's obviously different options that we can look at: dentures, implants, bridges, but we have to see what the actual arch looks like as well when we're doing that. Sorry. Okay, where to start? So yeah, like what I said kind of before was just taking a step back. There's just so much in that little paragraph, and there's going to be way more that when a patient comes up to you and tells you all this stuff in clinic. So you just have to think and look at things systematically. Otherwise, you can just go down a rabbit hole and just don't know where to start. Do your complete history and an exam, and have that also systematic, so you don't like have it all jumbled everywhere. It's in a good spot, so you can just kind of look. Oh, did they have pain? No, they didn't. Okay, what was the intraoral findings? Okay. So yeah, and then make a list of all the findings clinically and also radiographically. I think something that is not really, it's not overlooked, but it's just something that people don't really take as much time as writing a good radiographic report, because a lot of the stuff you can find on radiographs, because you don't see everything clinically. So write everything down. Is this what grade of a radiograph is this? What are the other findings? And it's not always something that you're looking for. If you're looking for caries, but then you see something like calculus, that's something you have to include, or whatever it is. And then create a list of diagnoses and then make a treatment plan. But how do we make a treatment plan? So we kind of look at a few things. In this case, we look at the acute problem kind of at the start. So kind of going back to that acronym of like, let's treat the acute problem first. So when we have a fractured tooth, we have to see, is the tooth vital? Is the tooth alive? In this case, do we think that it's involving the pulp? So what we do is we take a vitality test. There's different ways to do this. You can do the electric pulp test. You can do what I like to do is endofrost. That's a very good way of testing the tooth and then seeing if the tooth is vital. And then you also have to take a periapical radiograph. So what you're looking for in a PEA is to see if there's infection at the apex of the root. If there's a radiolucency or any kind of radiolucency there, or maybe widening of the PDL on the radiograph, this may be indicative that they have, say, something like apical periodontitis. They might have pulp necrosis or whatever it is. A lot of the stuff you can see on this radiograph. And then we also have to look at, can we restore this tooth? Is there enough ferrule? So a ferrule is how much tooth structure we have without any restorative material. Is there enough enamel there to support a crown? So there's specific dimensions, but we have to like see there's basically 2 millimeters kind of like width and like length of, is there enough to actually place a crown on this tooth? Do we need to do a post? Do we need to do a core? And then what is the patient's expectations? Do they want a crown? Do they not really care about the appearance? Is it pain? They don't really, care about the appearance. In the case of this patient, the appearance did matter, and rightfully so. It's right at the front of their mouth, so we have to take that into account as well. So for the sake of this case, it's just 4 simple diagnoses. After we did all the vitality testing, we found that nope, the tooth is vital. They did not involve the pulp. It was pretty close, but no, the pulp is not involved. It's vital. We looked at the radiograph. There's no widening of the PDL. There's no radiolucency. It's just a simple enamel dentine uncomplicated fracture, which is sometimes what it ends up being. I've had patients where we have had to do root canal where there's a huge fracture and we had to do root canal because there was no vitality in the tooth. Tooth was dead. There was pulp necrosis, chronic periodontitis, apical periodontitis. When we look at the radiograph, there was a radiolucency. We had to do root canal. In this case, no, it was a simple fracture. And then when we're looking at the mouth, we're seeing a bunch of caries lesions. So I didn't list all the teeth that were there, but let's say there was 7 total. So that's a lot of caries lesions. And then when we're doing the looking at the periodontal disease, and we come up with a diagnosis based on like the periodontal pockets and radiographs, we come up that it's stage 4 generalized grade C unstable periodontitis. So that is a pretty big deal. That is a very severe periodontitis and something that we have to look at the very start. Once we kind of get them, we kind of get rid of the acute problem. And then the patient also mentioned that they were missing some teeth on their upper right and left side. So that's also a diagnosis. So what is the treatment plan? So kind of going back to that acronym, we're going to start with the acute problem. So did the tooth really bother the patient? Were they really in pain? No, because they didn't involve the pulp. But at the same time, that patient was not happy. It felt sharp. They could maybe report that they cut their tongue or something on that tooth. And so we have to maybe do a temporary restoration, which you can do in that first appointment. Sometimes patients will come into this stuff into the emergency clinic or the casualty clinic, and that's when you kind of do this stuff. So sometimes you can even do a temporary restoration with composite. Might seem like, oh, it's a big procedure, but if you're going to do a crown on this tooth eventually, it doesn't have to be the most perfect shade match or whatever, but it still has to be very sound. It still has to be a very good restoration. And obviously you have to have a good shade, but you're gonna have to put a crown on this eventually, especially looking at how much tooth was gone. Crown is probably the best route to go. In terms of prevention, he mentioned a lot of things. He didn't brush his teeth very often. Let's say he brushed his teeth once every few days. That's not good in dental school. And obviously, your dentist always tells you you got to brush twice a day. So it's not as simple as just saying you need to brush twice a day. And they think, okay, yeah, I'll brush twice a day. It's not that simple. We all wish it was, but it's not. It's a learning curve. And we have to kind of approach patients of trying to like gradually get them where we want them to. So if they were brushing their teeth once a week, even getting to 2 or 3 times a week is a big improvement. And then obviously the ideal thing is getting them to 2 times a day. But if we can kind of at least get there some way, somehow, that's even better. And then looking at the diet, because you don't just develop a lot of caries lesions from anywhere. Yes, it's not just about the amount of sugar you take, obviously it's the frequency as well, but we have to take a look at the diet and if something can be changed. Does this patient snack a lot? Because I feel like snacking is one of the most important things you have to look at when you're examining the diet. When are these guys having the sugar? Are they having it throughout the day? Are they having it right after lunch and then they're having it with their afternoon coffee break or tea? Are they putting sugar in that coffee or tea? When are we doing like, so it's really important that we also look at the diet. And maybe something that I used to do is I would give them, my patients, like a sheet of paper, and I would be like, you know what, I want you to just write down what you ate the last couple of days and what you ate on the weekend, and then we can kind of get an idea of the general diet that you have, and then we can kind of see when you're eating this, and then we can kind of tailor a new diet and to kind of help prevent any caries lesions or whatever in the future. And then we have to stabilize that periodontal treatment, because so the diagnosis came back that it was really severe periodontitis. So there's very little bone left. He's probably going to lose a lot of teeth if we don't stabilize his periodontitis. It's an active disease, so we have to do some cleanings. And then some of those caries lesions, sometimes people think, okay, well, we can just do caries with the definitive treatment. But if it's like an active caries lesion, if it's kind of bothering the patient, we can remove these caries lesions and we can replace them with temporary restorations, such as like GIC. Even though we're going to eventually restore it with composite, it's still important to get rid of that caries, and if they're in pain or something, to get them out of that pain, which would kind of go back to that whole acute problem as well. And then we're going to do some definitive treatment in this case. So there's carious lesions. Yes, you can always fill them with amalgam. There is some cases for that, but let's just say for simplicity's sake, we're going to fill them with composite. And then going back to that tooth, so we had placed a temporary restoration on that fractured tooth, but the patient is not really happy with that, and he actually had a crown on his other tooth that he had fractured as well from a few years before, and he liked having a crown. It didn't bother him, so we're like, okay, we have to match this crown. And then we have to also take into account that the patient said that he wanted to replace the teeth that he was missing on his upper arch. So I don't have a picture of it, but let's just say it's a bilateral saddle. He's missing teeth. He's missing all of his molars on both of his right and his left side. So what's the best way to approach this? Do we do implants? Do we do bridges? In this case, probably the best way is to do a denture. I didn't include a medical history, but that's also very important too. Let's say the patient is on bisphosphonates or something like that. Implants are very invasive. We have to be very careful also with extractions. You don't want to get Bron J or something like that. And then the implants are very expensive, clearly. So it's not always an affordable option. Bridges, you don't always want to do like a bridge where there's nothing really to support it on another side, like it's not a fixed bridge. They just don't have as much of a great lifespan, and the patient is open to a removable device, so a denture is a decent option. And then maintenance, clearly, so just always making sure that they come in for their follow-ups and preventing any future disease. So where do we go next? So we're gonna obviously, once we treated that acute problem, like we mentioned at that first visit, we're gonna do some prevention. So fluoride sometimes is a very good option, especially if they don't brush their teeth. It also is very good if they have dentinal like hypersensitivity. It's very useful in that sense. We did the oral hygiene instruction, but then also kind of going back to that where I was saying last time was oral hygiene is not as simple as saying just brush your teeth twice a day. You have to physically show the patient how to brush their teeth, what the best technique is, what the difference between an electric toothbrush and a manual toothbrush is. It's not, and sometimes it might be silly, but you can get a typodon out and you can show the patient this is the way you're supposed to brush your teeth. And you know what? Can you show me how you would do it? And it's a great concept for them because they genuinely don't know this stuff. And then they're more inclined to do it. Usually with my patients, I always recommend an electric toothbrush, but as long as they are using a manual toothbrush correctly, it doesn't really matter. Always using a soft toothbrush as well. Patients kind of have this thinking that, well, if it's soft, it's not going to get rid of all the plaque, but then they brush too hard and then they might have tooth wear. They might have abrasion or something like that. And then looking at the diet again, like, so I mentioned that like frequency is very important, and then kind of going back to the Stefan curve of the pH levels and making sure that we don't snack, because then the acid in the mouth, it's not enough time to neutralize, and that's when caries starts to form. So explaining this to the patient, it might sound like very complex concepts to us, but if you take the time to explain it to them and they understand it, they're more likely going to be listening to you and thinking, okay, well, that makes sense logically, I won't snack because that, acid, that's not good for my teeth, and we don't want more future caries lesions. And then stabilizing active disease. So the pictures I have here, that is what supragingival calculus looks like. That is usually what the appearance of somebody's mouth is when they haven't brushed for a long time. So that plaque, it's very hard and it's calculus now. So it's very difficult to actually remove this type of calculus with just like a hand scaler. Usually you have to use like an ultrasonic. It will be pretty painful for the patient in terms of the gums being tender, because it's just they're very inflamed, as you can see, like the redness and them being kind of puffy. So you have to warn the patient about that. You might not think about consent when you're just doing cleaning, like a simple cleaning, but no, it's important. And then once you remove that calculus, then you can get a proper reading of like what the periodontal pockets are, and that's how we can establish our correct diagnoses. Usually you can like diagnose like perio kind of based on the x-rays, but then it's also good to always check the periodontal pocket depths. That's how we know if there's also bleeding on probing, because that's when we know if the disease is active or not. So we want to make sure we do that. So yeah, it's just a simple cleaning, but you can see the difference. You can also see some staining on this patient's teeth. So just a simple scale and polish, and wow, they look really good. And then just regular intervals. So sometimes people, okay, well, I clean my teeth, so I don't really have to come back for another whatever. But with these types of patients, we have to probably have a different interval time period of seeing these patients. Sometimes it's within a few months, few weeks, and we want to see this improvement in the periodontal pocket depth. So what I mentioned was the subgingival scaling. So when you're scaling the teeth underneath the gum, there's plaque on the radiograph. I don't have a picture of it on a radiograph, but like you can see like radiopaque areas on the radiograph, and that's where calculus is underneath the gum. So we have to get rid of this. Otherwise, the periodontitis is not going to get cured. So then we need to remove that and then give it some time to heal. And then when we're checking at these interval appointments, we can see if the periodontal pocket depths are decreased. So rather than maybe, I don't know, 7 millimeters at the next visit, it's 5, and then maybe it's 4 millimeters, which is it's a big improvement. And then like what I had said before, if you see like a lesion like this, that's very soft caries, you can see that it's not hardened, it's not inactive, it's very active. You can remove the caries and you can place something temporary like GIC, especially if it's temporary and it's bothering the patient. It might not be the reason for attendance, but when you start looking at the tooth, it could be reversible pulpitis, and then you might have to treat it that way, remove the caries, put a lining or something like that, and then kind of monitor that. And then once all this is done, once all that disease is stabilized, then we can move on to the restorative treatment, which is so in this case we're going to do some restorations with composites, so removing like the caries and placing restoration. So just looking at this picture here, it's a very big carious lesion in that area of that molar. You can see like that big black area, but then you can, even looking at the fissures on this patient, you can see that there's kind of like this orange and brown area, and maybe when you probed it, it did feel a little bit sticky. So you can't just leave that. You have to remove that, and then once you're going to get into there, you can see, oh wow, there was caries, and then you remove that, and you get to the dentine, and then you see that all the caries is removed. So you want to, so there's two types of like dentine. There's the caries affected dentine and this caries infected dentine. So you want to remove the caries infected and leave the affected. And that's another thing with being like very, like just not removing as much tooth structure as minimally possible. You want to keep as much tooth structure as you can. So we remove all the caries, and then we decide to restore that, and that's a very good restoration. You can honestly almost hardly tell that it's a composite restoration. They did a really good job. And then so once we get rid of all the caries and we restore that, then we can kind of look back at that tooth. Okay, so he fractured his upper tooth. How were we gonna do that? What material is the best? Is an all ceramic the best because of the aesthetics, or is a PFM the best because it's not as invasive? We're not preparing as much tooth structure as if we were to do an ACC. And I feel like patients are very, from the get-go, they want to just do the best aesthetics. But when you show them pictures from other cases or whatever from other patients, like they can see, oh, okay, PFM, you can't really see the metal that's on the palatal surface. And it's just not as invasive, and that's what we're trying to do, especially if the tooth is fractured. We don't want to remove as more tooth than we need to. So in this case, we're doing a PFM crown. Um, and then, so your prep is, basically kind of the same thing as an ACC, just is not as invasive on the platel because we're putting metal there. But then we're thinking, okay, well, the patient wants to replace those teeth on the upper, and he has bilateral saddles. There's not many teeth to support this denture. So we're going to try to get as much out of what teeth are present in this case. So it's called a milled crown. So basically, what a milled crown is a crown that's designed to support a denture. So it has denture features in it. So when you're preparing the tooth to support a crown, is you don't have to really change anything with how you're approaching the prep. You just have to send the lab something beforehand saying, you know what, like with this crown, is it possible to place a cingulum rest seat on the actual crown? So when you bring it back, it's something that we don't have to actually touch the crown. It's basically the way we want it. So it's, I don't know, from the picture you can kind of tell, like here it's kind of like indented a little bit, or not indented, but more of a flat area. So that is able to support one of the rests for your denture design. So it's a very useful tool. I'm really glad that I was able to do a milled crown, and just seeing how we can kind of tie different things together in terms of, okay, well, we're doing a crown for this tooth, but there's only a few teeth in the upper arch. This would be a very strong tooth to support this denture. How am I going to do this without damaging this beautiful crown that we just created from the lab, and just being able to do that? And then looking at, once we've done all that, we have the crown, we want to replace those missing teeth, because when you're missing a lot of molars, it's not always about aesthetics. Sometimes with the patient, like, it's very difficult to chew without your molars, and it's very useful to have a denture. Once again, since this patient had periodontitis, we have to make sure everything is stabilized, because if you don't stabilize perio and you put a denture, it's actually causing more of a problem, and it can actually worsen the perio. So we want to make sure that's all stabilized as well. So let's just assume that we don't know how to make a denture. And what's this thing called the altered cast technique? Like, where do we start with this? So basically, what you want to do is we place the crown, everything is done, basically definitive, fixed. So it's kind of the same approach to any regular denture. You want to take your alternate impressions, and you're going to have your study model. From before, you kind of have a rough idea of, from your other study cast, like what, before you did the crown, like what teeth are there and the type of denture design you want to implement. Since you sent to the lab, I want a milled crown to support this denture. So basically, yeah, once that you do all that, you have your study models, you create your denture design, then using those study models, you create a special tray, and that's when you can take another impression once you've done like your rest seats or whatever it is like that your denture design requires. So let's just say that he had a premolar and he was missing some of the molars, and he wanted to do like a distal rest seat or something like that. So that when you take that secondary impression, that rest seat is taken into that impression. And then so with that, you have that special tray, and then you can then from that step send to the lab, I want a framework. So in this case, we're doing a cobalt chrome denture. So you say, okay, we took this impression, this special tray impression, secondary impression, we used PVS. Okay, so can you create a metal framework with this impression that I've sent to you? But also, with those bilateral saddles, can you add a special tray onto that? So when they sense this back, they have the framework here, but as you can see, they have this saddle here. So that's actually not part of the denture yet. That is the special trays, and that's what's called the altered cast technique. You're kind of implementing like a special tray of something that you would do for an edentulous case when you're doing a full denture. So you're mixing both like a partial denture and a full denture into one. And you're kind of taking the advantage of whatever teeth we have here, but he's missing a lot of these teeth. And it's very useful because with those bilateral areas, like the soft tissue, like the gingiva, that's what's supporting the denture. So we want to be as accurate as we can. So with this, then they'll send that back. You can have wax onto the framework. So usually when I did my denture cases, I would usually get them to put like a wax rim on top of the framework when they got that back. And then, so let's just say there was wax rim on here. We try it into the patient's mouth. It fits nicely. So then we're also going to take another special impression or secondary impression. We're going to put some PVS. You can put PVS. You could, I guess you could technically also put zinc oxide eugenol or something because it's an edentulous case. But when I would do this technique, I would just use the PVS. And then you take another impression and then you send that back to the lab and say, okay, can you create now a trion with the wax centurion with the teeth in present. So like at this point, you would also have done your shade matching, looking at like the crown that you also did, getting that shade. And then from there, it's basically just like the last step kind of. And then with the wax there, we try it into the patient again. And we're just seeing that, okay, we're happy with the bite. Everything is okay. He's very happy with the appearance of the teeth. Okay, now we're going to send it for a finish. And then that's when they create the final denture. So I don't have a picture of the final denture, but that's kind of the concept behind the altered cast technique. So I think what's interesting with this case is like you could just not think of both the milled crown and the altered cast technique, and you could just do a basic crown and you could just do a cobalt chrome. But what we have here is we just don't have enough teeth to support maybe something that would be as long term, and we're taking advantage of what we have. And there's just so many different like ways we can do things in dentistry, and it's just such an interesting concept that's very useful. I'm very lucky that one of my patients did need the altered cast technique because it's something that you read about, you learn about in lectures and all that, but actually implementing it, and then the result was very good. So patient was very comfortable with it because when you're missing especially teeth on your bilateral, there's just not as much support and everything. So having as much support from that gingiva as possible is very helpful to the patient, especially when eating and all that. And yeah, like this case, from what I'm like, it was a very great like aesthetic result. Patient was very happy, and obviously in terms of like function, it changed his mouth quite significantly. And also just like with these types of patient, you always have to maintain, and just once we've done all this beautiful dentistry, we still can't forget about the fundamentals and why this patient, all the other diseases that he had, like say the periodontitis, because if you're just you don't you kind of go back to your old ways, you don't properly clean your teeth, the perio will return and the denture will fail. You'll lose teeth because there's not enough bone. So it's very important to always tell the patient, we're not completely done here. And he maybe is a dental student, yes, like I'm gonna graduate, I'm not gonna be here next year, but I'm referring you on to my the next person, and they will like take over. But it's still important that even though we finished our treatment together, to come in for your intervals of checkups and cleanings, and just making sure that whatever we achieved here in terms of your oral hygiene, that we stay at that, and we still brush twice a day, and we floss, because flossing is so important, guys. It's literally what will help prevent periodontitis. Yes, there's different things you can use like TP brushes or such things like that, but it just, yeah, flossing is just, it's just such a helpful thing that people just think, well, it's just such a, I don't really want to floss today, but no, it really helps in the long run. And then back to the diet advice as well, it's just super super important. So yeah, that's kind of just kind of putting different aspects of dentistry together, like caries, crowns, dentures, perio, and looking at a case. So like with just so many things to it, and where do I start, and what do I do, and how do I not get overwhelmed with something like this? Because it can be overwhelming, especially if it's a case that you see in dental school and you haven't seen something like it, and you have to treat it, and you don't know where to go. But yeah, no, just take things like slowly, have a format, like something that's simple to follow. And yeah, like it's treatment planning. It's not really too difficult if you can kind of just look at everything from a a different perspective, and just try to simplify things. Don't make everything too complicated. Simplicity is key. So yeah, we covered a lot in so little time. But if you guys have any questions, I'm open to answering anything.
Thank you, Dylan, for that amazing presentation. It was very holistic and thorough, and yeah, I thought that was really great. I do have one question. This might be kind of hard to answer, but I want to pick your brain a bit. So, you talked about first like treating acute problems that patients come in with, or like, I guess kind of like treating their chief complaint. But I feel that sometimes if, we have patients that come in they only come in with their acute problems and they don't want to come in for their routine maintenance for whatever reason. So I guess my question is, how do you get patients to be more motivated or consistent about coming in for like their preventive care
Yeah.
and their like routine maintenance rather than just coming with like problem only visits? Or if you
Yeah.
have thoughts about that.
No, yeah, for sure. Because it's one of those things, a lot of these patients we do see in emergency care, and they are only here because it's something like they have pain or whatever it is. So, say if we're looking at something like periodontitis, it's something that you can see clearly on a radiograph. It's especially in this case, if it's like very severe periodontitis, there's so little bone supporting these teeth. And I feel like when I showed patients that visual like diagram or not diagram, the visual representation of the tooth and just showing them that we have so little like bone to work with here. If you don't come into your appointments, because that's the thing, we can't force people to come to appointments. It's up to them ultimately. But if you don't come in, it's just not going to get better, and you will lose teeth. It's they're just going to fall out. The teeth are going to be so loose that if you don't come in. And I think that's just one thing when we kind of, it's not, you're not trying to scare the patient. You're just trying to be realistic with them that if there's always consequences to actions. And if we don't go this way, if you don't come into your appointments, yes, that is up to you if you don't want to come in, but there will be consequences. And in this case, if you're not treating the periodontitis, which is outside of the acute problem, there will be future problems down the line. And if you're maybe in pain or something, that there could be pain, especially down the line, not necessarily linked with periodontitis, but if we don't fix our diet, there another tooth will come in pain, and then you'll have to treat that one. Or if you want to have pearly white teeth and you want veneers, like we can achieve that maybe depending on what the case is, but we have to like take a step back and we have to come and treat our health. You know what I mean? Like I think if we kind of show them the roadmap of what can happen, they take it more seriously than you don't show them. Because I felt what was useful was just taking time to explain things to my patients and just show them case scenarios where, okay, if we don't do things, like if we don't treat caries, yeah, it might not be symptomatic for you, and it's not bothering me right now, but what's worse, like doing a filling right now or waiting till it gets worse, you're in pain and now you need root canal treatment, which is something that you will need unless you want the tooth extracted. But nobody wants to extract especially like something like at the front or whatever. Nobody wants to lose teeth. But I think just being like very like clear with them that these are things that can happen if we don't take advantage of our oral health. Sorry, take advantage of like taking care of our oral health and preventing stuff. Because we're at a stage now where we can stop things from happening. And it's just like with anything, right? If we don't put an intervention, whatever, like Murphy's Law, whatever is going to happen is going to happen. We have to kind of just. So maybe I hope that kind of answers that question. But yeah, just being really like clear with the patient and showing them things, and explaining things. They're very open to listening, and that maybe motivates them to actually come in and stuff.
Absolutely. Thank you for that. And I have one more question. How do you feel like um, this is kind of off topic, but how do you feel like you have grown into like becoming like a full-time practitioner? Like, how did you feel like the transition went from being a student to now being like a full-fledged dentist? Do you feel like there was a learning curve? You're still, feeling that way? Because I know you're still,
Yeah,
a
yeah.
recent grad, but how are you finding like that transition?
I think what it is like we're always learning still. Like even though we're finished school, even in 10 years from now, I'm still learning. But like learning from failure, learning from mistakes that you made in dental school, because that's, well, not that you want to make mistakes, but if you're gonna make some mistake, it's okay in practice. Sorry, in dental school. It's literally called school. We're learning from those things. And not just, oh, I didn't do this right, okay, well, but like actually learning from it, what can I do differently? And kind of just having a different perspective in your final year. So like the difference between my third year and my fourth year was trying to be like, what if there is no supervisor behind me? I know they have to check my prep, but what if there isn't somebody going to check my prep? Am I happy with this? Did I get rid of the caries lesion? Did I remove enough tooth structure for my crown prep? Do I need somebody to, like, you know what I mean? Because I would always think in a few months from now, there isn't going to be somebody to help me. Like, am I not doing the best for my ability? Like right now, can I not do better? Because yeah, like sometimes you do things, but it's like, okay, do I really want to help me? I don't really want to do this, but that's more in your third year. I think, yes, like the transition is just trying to have that perspective earlier on and not just like you're graduated and now you're like, oh, okay, yeah, so I don't have any help. So trying to be a little bit more independent in your final year is, I guess, like something that can help me, and just trying to not every 2 seconds, oh doctor, can you help me, like so and so, like, oh, is this, and just like actually like reading about things and understanding things, like what exactly is caries, what does caries like look like, and what does it feel like, because it looks kind of silly when you say like to like so many patients you're doing a, like say a caries removal, and then you come to the supervisor, all right, I finished the prep, and they're like, well, there's still caries there, and it's like, no, I think I removed it, and then they use the probe and they're like, does that feel hard, does that feel sticky to you, and you're like, that's something I could have checked myself, right? And then it's one of those things, the clinic is just going to be really long if you're just constantly being dependent. So just, doing your understanding what these things are. Why am I removing tooth structure? What is the point of removing tooth structure when I'm putting a crown? Oh yeah, so because we're putting something on top of this. Okay. Am I using my probe correctly? Am I checking the measurements? Yeah, okay. Check my putty matrix. Like all these things, like the concepts that we learn in sim lab, we learn them for a reason. Let's put that into practice, and let's just try to be as much independent as we can. And if we don't know something, that's totally fine. Like that's the place to ask questions. But yeah, like I guess the answer to that is just trying to, so it wasn't like a drastic change for me. So I think like now, like when we're doing stuff in practice, it's like, okay, I had this kind of mindset, especially in like my last couple months of dental school. Like I even told like a lot of my supervisors, like, I'm probably not going to come up to you a lot. I know I have to, because it's like for like whatever legal reasons, like you have to sign off on this before I move on to the next one. But like if you see something, like don't tell me, oh yeah, like you need to remove it here. Like be like, no, you're not finished or something, and then call me when you think it's finished. And I think that kind of trust with your supervisor is very important too, to show that like, look, I'm going to be a doctor in a few months. Like I know what I'm doing. You have that faith in me too? Okay. Because I feel like with my supervisors too, they have a lot more faith in you than you even do in yourself. And you got to trust yourself at this point. You got to trust all the knowledge that you've gained over these 4 years of dental school. You clearly know something at this point, hopefully. So trust in yourself, and yeah, and just kind of having that, and like doing things like this, like, you know, me discussing this right now with you guys, I'm like, oh well, yeah, I did learn stuff in dental school. Like me explaining it to somebody else and trying to simplify concepts, like it just shows like our knowledge and stuff, and how maybe some other people at dental school don't know some of these things, because the unfortunate thing is we don't always get to do everything in dental school. Like some of my friends, they didn't do an altered cast technique, or they didn't do a milled crown. We learned about it, but you can learn about things outside of school, and just constantly like getting involved in things like these is very important. We're not finished learning. I'm always excited to learn new things, such as implants, Invisalign, or whatever it is, like, or just even simple how to get better at caries removal or caries detection or whatever it is. So yeah, hope that answered that question.
Thanks so much. Yeah, I feel like now that I'm in my fourth year, I definitely want to implement that kind of mentality as
Yeah,
well. I'm not so dependent on my supervisor. So thank you for that.
of course.
Thank you so much, Dylan, for answering some of those questions. Those are definitely like great and a lot of good advice. Does anyone else have any more questions? All right, I think we might be good. But thank you so much, Dr. Dylan Sharma, for your time. I really appreciate the amount of effort and thought you put into this, and definitely learned a lot along the way. So thank you so much for your time.
No, thank you guys. This was awesome. I'm glad that I got to talk dentistry and all this stuff with you guys, and I hope somebody that you guys like learned something. So yeah.
Sounds good.